Welcome to the new iWorld studio. I'm so happy that you can be part of this live event, and with the most live person here, with Chris Starr, and we're talking about certainly the most lively topic.
Absolutely,
which
the
is
coolest.
the ocular surface. Now,
Yep.
it is, as they say in Boston, wicked complicated.
It is wicked complicated.
But you have, I don't want to say that you've taken the thought process out, but you've created what I need, which is a roadmap and an algorithm.
Yes.
I'm going to stop talking now. I want you to tell me what I just said actually means, and tell me about it.
Well, you're in the majority because on the ASCRS survey last year, 2 years ago, we saw that 83% of surgeons like you and me said, gee, we could use an algorithmic process because this is super complicated and we're really busy with all this other stuff, especially on the preoperative surgical visit, which is already really complicated, right? You've got IOL discussions, and if it's LASIK, all of that stuff, and the complications, and informed consent, and sometimes costs out of pocket for multifocal lenses and what have you, LRIs, toric lenses. And so and lots of testing too, right? Biometry and keratometry and tomography and topography and so on and so forth. So that visit by itself, without thinking about the ocular surface, is complicated and really long and arduous. Then when you throw in the ocular surface, which you really have to because you ignore it at your own peril and the peril of patients. So you have to address it. And so what we decided with the ASCRS Cornea Clinical Committee was that we would try to put together a simple algorithm to follow that technicians, heavily dependent on technicians and objective point of care diagnostic tests and things to take the surgeon away from it all so that it reduces the chair time that would be otherwise needed for the surgeon doing everything, going in there and examining and talking. So the algorithm, it looks, there are some great things. The poster, it's here as a poster.
Your poster.
My poster, yeah, an actual poster though. It's something to hang up on a wall. And there's a light box out there where it's gigantic. I got to remind myself to take a picture in front of it. And it looks at a first glance like, oh my gosh, like that's complicated. And I showed some in my talk, some handwritten ones I had done early on that were, enormously complicated and, of course, overly complicated. But this one, it looks a little complicated at first glance, but it really isn't. And it's, again, heavily dependent on other office staff and very objective, so that when you, as a surgeon, walk into that room, you have all of this information, objective information, symptoms, signs, and objective measurements, and all of which gives you a lot of information, but you can almost figure out what the patient may or may not have based on all of that data. And then you go in there, you do a quick exam, because no ocular surface algorithm would be complete without an actual exam. We have to look at it, but the exam doesn't have to be onerous or very long or complicated. I would say all of 30 seconds to do what we are calling the LLPP, look, lift, pull, and push. Look at the ocular surface, look at the lids, look at the base of the lashes, look at the tear meniscus, lift up the upper lid, look at the superior cornea and the superior conjunctiva to look for SLK and EBMD and things like that. Pull the upper lid. That'll tell you, is there a floppy eyelid here? Because that's often overlooked source of ocular surface disease. And then push on the meibomian glands, express the glands, see what's going on in there. And you've got that. It takes 30 seconds. You've got osmolarity, MMP9, and a symptom questionnaire that we created for this process, specifically for the ocular surface patient in the preoperative setting. And so you've got this process now that took a while to make, but it turned out pretty nice, to make your life and all of our lives easier when it comes to the ocular surface stuff in the context of the pre-op surgical visit.
Yeah, and the way that I think of it is that when you look at the algorithm and you say, boy, this is really complicated, it's really the equivalent of looking at a map and saying, boy, there are a lot of streets.
Yeah.
You don't have to go down every street.
That is true.
But
Yeah.
when I follow the map to my destination, I know where I am. When I go through the algorithm, what do I get out of it? What does it tell me?
So it's going to tell you essentially, is there ocular surface disease present? Now we know that it's very common, and we've done studies. I've done a study. There's a FACO study. Priya Gupta and I published something last year that showed in patients preoperatively, 85% of them who are in the asymptomatic group, over 80% will have some abnormality, osmolarity or MMP9 in their ocular surface testing, and 50% of patients who are asymptomatic will have both of those tests be abnormal. So we know that the prevalence is very high. So this algorithm is going to give you very objective information as to A, what subtypes of ocular surface disease are present, B, how severe they are, and C, whether they're visually significant. Now, if we told every person who has a form of ocular surface disease that you have to delay their cataract surgery, let's say, to treat it and this whole rigmarole, then almost every patient who we saw would be delayed and postponed. So one of the key caveats with this algorithm is we identify visually significant ocular surface disease and only delay surgery when that is present. And of course, there are lots of things that qualify as visually significant, but corneal staining, inconsistencies with the keratometry and the topography, or a topography that is what I like to call irregular pattern, where it just doesn't. It's not ectasia. It's irregular, but it fluctuates between blinks and tests, and other things can, and also very importantly, visual significance can also be infection risk. We don't forget, but it is important to remember that something like a bacterial source of ocular surface disease, usually anterior blepharitis, but there are others, conjunctivitis, that, if left untreated or unidentified, could theoretically increase the risk of, say, endophthalmitis or something like that. So all of those things are considered visually significant. The algorithm identifies those and allows you to justifiably treat that. Sometimes you have to delay the surgery if the surgery is in a few days or next week, but you're still benefiting the patient greatly by postponing, as much of an inconvenience as it is to postpone, but to do the right thing, treat it, reverse it, especially those patients who want, have high expectations, high visual demands, spectacle independence, or might be paying out of pocket for a multifocal IOL or a premium lens of some sort. It really behooves you to identify it, treat it, and give them the best visual outcome for their money.
In Manhattan, as you and I know,
Yeah.
there are no demanding patients.
No, none.
Doesn't happen. There are. I have a question and a concern, and they're both the same. Does the algorithm recommend therapy, and is it going to recommend a therapeutic modality to which I don't have access?
That's a really good question, and I should say up front that the algorithm does recommend certain diagnostic tests, which not everybody has. Not everybody has osmolarity or MMP9 in their office, but we chose those specifically because, one, they're inexpensive to adopt.
Right.
Usually they're reimbursable in most practices, or at least break even at worst. They're technician-driven, and they're really good tests. There's very high sensitivity and specificity, and that combination not only identifies dry eye and severity of dry eye, but also other ocular surface diseases. So those two in combination make a lot of sense, and it's not a big cost for the practice. Say something like LipiFlow. Now, we don't say every patient who has MGD has to have LipiFlow or a thermal pulsation device of any kind. They're all cost money to buy, and not all practices have them. So we wouldn't dare say, gee, if you don't have those tests and you don't follow this algorithm to a T, then you're committing malpractice or breaking standard of care. Not at all. It's the algorithm, and all the steps are suggestions. It's our sort of method of doing it, but there are lots of alternatives, and you can adapt it any way you like. And if you don't have microblepharoexfoliation in your office, you can treat the lid in other ways, with antibiotics, or just taking a Q-tip in the office and scrubbing them. Education, patient education is hugely important, with the lid scrubs and warm compresses and all of these things, omega-3s if you do those. We basically try to incorporate everything that's available so that kind of why and where you would use X treatment or this medication, punctal plugs, whatever it may be. There's so many things available right now, which is actually why we did this, because it's so confusing for most people. Like, oh my God, there are all these things that are available. I don't know where to start with this stuff. What do I need? What don't I need? How do I do this? So we basically, our goal was to incorporate everything. You choose what you want to adopt into your flow, into your office, and all of it, none of it, some of it, it's up to the practitioner.
This is great stuff. I don't have to tell you, having no data is terrible. Having a little bit of data is great. Having a lot of data is terrible. and you're helping me through this morass. Chris, I want to thank you very much. This is an enormously complicated topic. We've just scratched the surface.
Nice.
But I do want to thank you for your recurrent generosity with your time, and I want to thank you for participating in the live event in our new iWorld studio.
This is really cool. I love this. But Josh, of course, as anytime you want me, I'll be here.